Over the last sessions that I've had with you, there are two really important points that I've been trying to get across. The first is, of course, is that diabetes, or the diagnosis of diabetes, is about having multiple pathologies that are causing the disease, not necessarily just one pathology. And the second point that I hope that I have gotten across is that we've got multiple medications that have been created. They have different mechanisms to target these different pathologies. So theoretically, one should be able to hopefully figure out what the underlying pathologies are under a person who's got diabetes. And once you've figured that out, then hopefully you can target or pick medications to target their different pathologies, which would presumably simplify things, given what we've got available for us. So for the next 30 minutes, what I'm going to do is spend some time focusing on what tools have we got available to us for determining the underlying pathology that we have in a person with diabetes. You know, in the good old days, for those of us in primary care at least, it was very easy to make a diagnosis of diabetes because we really only understood that there were two types of diabetes, type 1 and type 2. And it was also fairly straightforward, or so we believed, to make the distinction as to what a person had, because we believed that if you were a child, you had type 1, and if you're an adult at the time of diagnosis, then you must have type 2 diabetes. Once we had decided on what type of diabetes a person had, well, then it was absolutely straightforward about what you picked for their management. Type 1 diabetes, insulin; type 2 diabetes, an oral hypoglycemic, and back in the good old days, which wasn't so long ago, we only had one or two of these, a sulfonylurea or a metformin. So it was fairly straightforward. Unfortunately today, it's not quite so simple. In fact, it's pretty darn confusing for most of the time, and that's because of a number of developments. Not only developments in our understanding and our knowledge around diabetes, but of course developments in the number of delivery systems and insulins and medications that we have available for treating diabetes. So what are these developments? Well, the first one, of course, is that we've got an obesity epidemic. All right? We've not only got adults who are obese, but we've got children who are obese. So no longer is type 2 diabetes just an adult disease, it is also a child disease. We also have developed tests for testing antibodies. We've got commercially available tests, and once, of course, we started doing them on adults, lo and behold, we discovered that adults can also get autoimmune diabetes, late autoimmune disease of the adult, and type 1 diabetes. As I've mentioned before, we had a new onset type 1 diabetes aged 86 years of age a couple of years ago. So no longer can we use age as a determining factor for deciding on the type of diabetes a person has. A second change, of course, is our understanding that there aren't just two types of diabetes. There are all sorts of, more than 50 or 60 different types of diabetes, and some of these we are beginning to realize are a whole lot more common than we ever thought, such as monogenic diabetes is going to really come up and hit you because we're realizing it's quite common. Also, we've got hemochromatosis causing diabetes, and so we're needing to understand a whole lot more about the different types of diabetes. Another development, of course, which I have gone through with you, is this understanding that there are multiple pathologies that are contributing to the diabetes, but more than that, even if you take two people who have the same diagnosis of diabetes, two people with type 2 diabetes, each one is going to have a unique set of pathologies underlying their disease, so they're not identical, even though they've got the same diagnosis. Furthermore, a person who carries the diagnosis of type 2 diabetes may well have a different pathology at the beginning of their disease than they have at the end of their disease. Here you can, I don't know that the light works very well, but a person at the beginning of their type 2 diabetes may well have sufficient pancreatic function, not sufficient enough to overcome their insulin resistance, but as they progress through the disease, they develop pancreatic insufficiency. So one person can have different pathologies throughout their lifespan. And then, of course, the other development we've got is the huge number of medicines, all of which have different mechanisms of action that are being used to target the different pathologies, and many of you may feel a little bit like this when you're trying to come up with your decision around what you would like to do with the patient who's sitting in front of you. And so indeed today, things are beginning to look not quite so simple as they did before. They're beginning to look rather messy as to how you proceed with making a diagnosis and making decisions around your management. So how can we simplify this? Well, one of the things that I'm proposing is that, in fact, what we can look at is actually the pathologies that a person has, and if we understand the pathologies, then we can match the medications to this. I am not, however, suggesting that we do not determine what type of diabetes a person has. There are a number of reasons for this, and so I still believe that you have to go through the steps to figure out what type of diabetes they have. And what are the reasons for this? Well, the first reason is because there are still types of diabetes that actually do dictate management. The simple one, of course, is type 1 diabetes. If the person's got type 1 diabetes, you need to give them insulin. Monogenic diabetes, if you've got a glucokinase variant of monogenic diabetes, you don't treat it. The person may have high blood sugars, but in fact you do not treat glucokinase deficient people at all, because they don't develop the complications. HNF1 alpha, another type of monogenic diabetes, does not do well with insulin management, does very well for life really on sulfonylureas because it doesn't necessarily progress. So there are certain types of diabetes where the diagnosis will determine the best management for them. Another reason why it's important to determine the type of diabetes is for genetic reasons. Particularly with the monogenic diabetes, they're often not picked up until later in life. However, they're inherited in a dominant pattern. So if you pick up monogenic diabetes in an adult, then you absolutely must go and look at the rest of the family, and you may then pick it up in all the 10-year-olds, 12-year-old children, and then you can start management early as opposed to later. So it is important to be able to know whether you need to screen families. A third reason is for future management. We don't have all the managements available to us yet that we're going to have in the future, and it may be that we get new management regimes or new management options coming up that are particularly targeting certain types of diabetes. And if you don't know the type of diabetes that your person's got, then how are you going to jump on the new information that we have and use it to the person's advantage? And finally, there's that whole issue of accessibility to treatment. I certainly believe that there are probably still insurance companies in the United States, certainly in New Zealand, where the government pays for health care. There are certain treatments that are only accessible to certain types of diabetes. For example, Lantus only just recently became available for type 2 diabetes in New Zealand. It was also always only available for type 1. When I was a resident here in the United States doing my training, believe it or not, insulin pumps were not available for new diagnosis of type 1 diabetes in an adult. It was only available if you were a child. It didn't last for very long, but we had to do a lot of fighting to get our adult type 1 patients insulin pumps. So accessibility to treatments is another important reason. However, let's focus a little bit on determining the underlying pathologies. And so what are the tools that we use? Well, it isn't rocket science. I know that there are a number of you sitting on the edge of the seat hoping that I'm going to change your life forever, but the truth of the matter is it's basically medicine 101. Patient history, family history, clinical presentation, and some blood tests, a couple of blood tests that we have. The rocket science that you have is actually the knowledge that you bring to the questions that you're going to ask these patients, and the knowledge that you have that are going to give you the red flags depending on the answers that they give to your questions. And to so kind of demonstrate that, I'll go through some of the questions that I ask the patients that when they come in to see me. So taking a patient history, how were you diagnosed? Was it by accident? Did somebody do a screening test? In other words, were you asymptomatic at the time, which would imply that you have sufficient pancreatic function around? Or did you present complaining of some thirst or urinary frequency, which would imply that you've got pancreatic insufficiency at the time of diagnosis? Did you present with your first diagnosis of diabetes having just had an MI or a stroke? It would imply that you've had diabetes for a while. It suggests metabolic syndrome, insulin resistance, all right? What about at the time of diagnosis? How old were you? Were you 20? Were you 35? Were you 45? Were you 65? All of these will group different chances of what kinds of diabetes you might have. Did you have any symptoms? I've already gone through that. Did you have retinal disease? Would imply that you've had diabetes for a long time if you present, or it's more likely type 2 diabetes. Were you obese or thin at the time of diagnosis? In the service that I run, I have people referred to me for management of diabetes, and they may have had diabetes for 25 years, and they may walk into my office overweight. But I need to find out what they were like back at the time that they were diagnosed. I had a lovely Maori young lady who was referred to me with the diagnosis of type 2 diabetes. She was overweight. She'd had diabetes for about 25 years. Turned out when she got diagnosed, she was in her mid to late 20s. She was solid. She wasn't thin, but she was on the national field hockey team for New Zealand. She was playing 5 or 6 hours of hockey just about every single day. Did she really have type 2 diabetes? These are the kind of questions you want to be asking your patients. As it turned out, she did not. So it's really important to dig back into their history and ask some of these questions. Are you on insulin? If so, how much? If they're on 100 units of Lantus a day, you know that they've got some insulin resistance. If they're only on 15 units a day, then you know they're insulin sensitive. How soon was insulin introduced after your diagnosis? In other words, did they rapidly progress into pancreatic insufficiency? That would certainly take you out of the realm of type 2 diabetes, possibly. Okay, these are all possibilities. Do you have a history of gestational diabetes? An important question for the older population. I ask, do you have a history of large babies? They don't generally understand what gestational diabetes is. If you've got a 20-something-year-old who presents with gestational diabetes in their 3rd trimester of pregnancy, you can bet your bottom dollar they inherited a lemon from their parents. They don't have great pancreatic function, which is why they're at risk of developing type 2 diabetes later on. But they have primarily pancreatic insufficiency. They don't have necessarily just insulin resistance. In fact, I'm going to say that again. Gestational diabetes is actually a presentation of primary pancreatic insufficiency. What ethnicity are they? Are they Indian, Asian, Maori, Pacific Island, African American? Indians and Asians have our highest rate of supposedly type 2 diabetes in the world because of insulin resistance. And so if you've got an Indian, not an American Indian, or an Asian sitting in front of you, then you can make the assumption that they've got significant insulin resistance on board. What about past illnesses? I have a number of patients who had cholecystectomies or had pancreatitis and were in the intensive care unit for 3 or 4 months just prior to their onset of diabetes. You can bet that their diabetes is not due to type 2, of which all of them, I have to say, were carrying that label, but due to pancreatic dysfunction secondary to pancreatitis. Alcohol use in New Zealand is a huge issue. We've got a big alcohol problem, and I imagine that a lot of our type 2s, actually, it's alcoholic pancreatitis that we've got going on. And finally, a really important question is, do you have any other autoimmune disease? Thyroid disease, celiac, low B12 would indicate celiac. Do they have a skin rash that they're constantly struggling with? Could that be celiac? And inflammatory bowel disease. I've got one patient, he unfortunately didn't spread his autoimmune diseases through the family. He got all of them, and he has thyroid disease, type 1 diabetes, inflammatory bowel disease. He's just developed pemphigus bullous, and he's got rheumatoid arthritis. 5 autoimmune diseases in one person, so they are associated, and this should send up a red flag if you've got a person who's got some of these and they're not carrying the diagnosis of type 1 diabetes. Family history, also extremely important. Who has got diabetes in your family? Your grandparents. What's your mum like? What's your dad like? How old were they when they got it? Were they overweight? Were they thin? Are they on insulin? Are they on oral medications? Some people can't tell you a whole lot about their family history, but I can tell you this is probably one of the biggest eye-openers that I've had in the time that I do it, and I always ask for this. I had an Indian lady come in to see me. She was in her early 60s. She was fairly petite. She was a little bit overweight. She carried the diagnosis of type 2. I had no reason to suspect she had otherwise, except I then asked her her family history. Her mother got diabetes in her early 60s, and she was tiny apparently also and not overweight at all. She had 12 siblings, 11 of whom had diabetes. All the men in her family got diabetes around the age of 45, and all the women in the family, 45 to 50, and all the women in the family got diabetes somewhere around the age of 55 to 65. Boom, hemochromatosis. Sure enough, we did the test, and lo and behold, she was positive for it. We actually had to send out messages all over the world because these family members lived everywhere. They now have screened all of the children and the grandchildren, and so there you are. We can prevent the development of diabetes by making sure we have the right diagnosis. Please ask your questions about the families. What medicines are they on? I asked you about that. Who's taking insulin? Monogenic diabetes, dominantly inherited, okay? Again, you will find multiple family members with the diagnosis of diabetes. The classic for a misdiagnosed or a missed monogenic diabetes diagnosis is that every family member has been diagnosed with a different kind of diabetes. You've got some people who have type 2 and some with type 1, and some are on insulin and some are on oral hypoglycemics. That's big red flag for monogenic diabetes, okay? And of course, history of cardiovascular disease. Do they have high cholesterol, hypertension, and history of MIs or cardiovascular or stroke, and that would imply that they've got metabolic syndrome sitting in their family, which would suggest insulin resistance. Family diseases of autoimmune disease, also another important question for the reason that I went through before, and of course, hemochromatosis. Generally, you know, you'd think that this might take ages and ages in your appointment. It doesn't take very long. Do you have anybody in your family who's got rheumatoid arthritis, thyroid, celiac, hemochromatosis? And most patients look at you with a frown on their face and go, never heard of them, never heard of them, never heard of them, and then you've done it. If the family's got it, they'll go, oh yeah, yep, I've heard of that. We do have that. So it doesn't take very long to go through a history with a patient. Clinical presentation is also important. Are they thin or obese? Are they losing weight on oral medications? This would imply pancreatic insufficiency. Don't base everything on their clinical presentation. Do remember to go back to the beginning of life when they first got diagnosed with diabetes. My wonderful story is of this morbidly obese person who was referred to me. 51 was her BMI. She was on insulin. She was on multiple shots of insulin. Her diagnosis was type 2 diabetes. I went back to her history at the beginning and some of the labs that had been referred through to me. She had always been obese. She had always been an obese child. She was diagnosed with diabetes in her late 20s. If I took a look at her labs, she wasn't particularly hypertensive, which was interesting. And you take a look at the cholesterol panel, that's interesting. She's got a high HDL. If you've got a high HDL sitting in front of you, you can bet your bottom dollar they do not have type 2 diabetes. If they've got a low LDL and they're not on a statin, they don't have type 2 diabetes. If they've got blood pressure that's either not requiring any blood pressure medications or is very easily controlled with one antihypertensive, then you can begin to make a little bit of a question of, is this type 2 diabetes? This woman I had sitting in front of me had a high HDL, she had a low LDL, she didn't have hypertension, and lo and behold, the doctor had also happened to have sent through the fact that she had struggled with anemia. We did a B12, it was low. She had celiac. She had positive antibodies, as it turned out. She had type 1 diabetes. She'd had diabetes for 25 years, thinking she had type 2 diabetes. In New Zealand, it was extremely important because it meant she could access a completely different set of insulins. So it is important to go through their labs and, again, activity level, and I've already given you an example of that. Their medication history, I find, is a real pointer. If you've got a person who's bottomed out on a sulfonylurea, you need to question whether or not you really think that they've got insulin resistance. If they're insulin resistant, they're not going to bottom out on a sulfonylurea. They're more likely to be insulin sensitive. Feeling sick on metformin. I do not have any evidence of this. This is purely from my clinical experience, but I found when people come in and complain of horrible diarrhea and really feeling horribly sick on metformin, there's a good chance that they don't have type 2 diabetes, or it's a little bit of a red flag to me that I should look elsewhere. I find that people with type 2 diabetes are much more likely to tolerate metformin. You'll also get people coming in saying, oh yes, we tried the Actos or the pioglitazone, and it didn't work. I was on it for 3 or 4 months, it didn't work. Well, if it didn't work, they didn't have insulin resistance. Okay, so some of this history can tell you about their underlying pathology. And then the same questions about the insulin. You will be getting a manual that goes along with this lecture, and in there I have given you a chart that actually gives you the questions and some of the conclusions that you can make from their answers to the questions. They are suggestions. They're not conclusive. They're suggestions that are going to send up red flags and also point you into the direction about whether or not you should be doing any kind of blood tests to help determine further what their pathology is or to help determine further what their diagnosis is. So what are the blood tests that you can do? Well, you can do antibody tests, and these are, of course, for autoimmune diabetes. We have a panel of commercially available ones, GAD, ICA, and IAA, that have been around for a while. Okay, these are expensive. They're not cheap. So don't throw them at everybody just because you think that this is going to sort you out. Please go through those questions of their personal and family history so that you can determine whether it's worthwhile doing these tests. We do, however, believe that about 20% of your type 2s are misdiagnosed, and the majority of those are late autoimmune disease of the adult. Some of them may well be type 1 diabetes who have been completely missed. There are other commercially available ones that have come out. They are also extremely expensive. If you find that a person, so GAD and ICA in particular will pick up about 80% of the people with autoimmune disease or that we believe have autoimmune disease. There is about 20% who come back as antibody negative type 1 diabetes. The question is do they really have type 1 diabetes or an autoimmune basis, or do they have a different kind of diabetes? And we're sorting out through that as well. However, there are some additional antibody tests that are available commercially at this point, and some of those negative antibody people come up as positive in those antibody tests. I would suggest that you pick up the phone if you truly suspect they've got type 1 diabetes, talk to a specialist and ask them if they believe that it's important or necessary to order the additional antibody tests. Genetic testing is also very available at this time for type 1 diabetes. It's not a commercially available option. However, there is an organization or an overarching research group, TrialNet, that's part of JDRF, that's actually international, and you can refer families that have somebody with type 1 diabetes to them, and they will genetically test the rest of the family. The information is not made public, and it therefore doesn't affect their ability to get insurance in the future. That is a very important question that you do need to address with the people. Some families, of course, don't want to know if their other children are at risk of getting type 1 diabetes. Some do want to know, do understand that if you are genetically positive, it's only a predisposition. It does not necessarily mean that you're going to get type 1 diabetes. Monogenic diabetes, we do have commercially available genetic testing for. These are single gene mutations that we look for. They are autosomal dominant, so if you find that you've got a person who's got monogenic diabetes, it is really important to screen the rest of the family and multiple generations in the family. Glucokinase and HNF1 alpha make up about 80% of the monogenic diabetes. There are other genetic tests. These are extraordinarily expensive. They cost about £1,000 in England, and they're upwards more of $600 or even more over here. Again, don't just do them at the click of a finger. I suggest that you talk to somebody if you suspect that a person has got it. At this point, at the recent American Diabetes Association, England is actually the centre of research really around monogenic diabetes, and one of the speakers at the recent ADA from England suggested that she believes that if you're diagnosed with diabetes that looks not like type 2 and you're under the age of 40, you're an adult, then it's a 5% chance that you actually have a monogenic diabetes. She also stated that she believes that probably about 1 to 2% of people who carry the diagnosis of type 1 diabetes actually don't have type 1 or autoimmune diabetes. They've got a monogenic diabetes. These are becoming much more important or prevalent than we actually truly believed. Any questions about the genetic testing or the antibody testing? So other tests that you can do, of course, is the oral glucose tolerance test, and this specifically is going to tell you a whole lot about the person's underlying pathology. I do this often to show the person what's going on with their own pathology so that they can actually participate in the management of their own diabetes. We have drawn a line through the picture before, and as we've pointed out, that on one side of the line we've got them when they're in their fasting state, if we check a blood sugar at that time, and on the other side we've got them in their postprandial state. Oral glucose tolerance test, of course, is going to check their blood sugar when they're fasting, and then you challenge them with 75 grams of glucose, and you measure what their blood sugar is an hour and 2 hours after they've had the challenge of the 75 grams of glucose. So it gives you very specific information about the two different sides of their physiology. About a third of the people with type 2 diabetes have a problem only on this side. So they wake up in the morning with a high blood sugar, but when they eat, their blood sugars remain more or less the same. Another third of the people with type 2 diabetes have a problem only on this side. They wake up in the morning with a relatively normal blood sugar, but when they eat, their sugars go zooming way up. And then you've got a final third of people with type 2 diabetes who have a problem on both sides. The only way you're going to determine that is by doing an oral glucose tolerance test. It is a lovely way of demonstrating to people how they can then pick and choose the medications that are going to best suit their physiology. A person who's got a problem on this side tends to have much higher insulin resistance peripherally. A person who's got a problem on this side has got central insulin resistance, and there's been quite a lot of analysis going on about what it means for your physiology to have a problem on each of the sides and which medications can work better for you. All right? So if somebody's got a problem on this side, it implies that they need to take an Actose or a pioglitazone or a rosiglitazone. If they've got a problem on this side, they tend to have much more pancreatic insufficiency going on, and it may be that you need to think about introducing insulin a little bit earlier than you would necessarily think about. So oral glucose tolerance gives you specifics about the underlying pathology. And finally, we've got the fasting C-peptide test, probably the one that everybody's been waiting for, because I've now been doing this for years as a way of determining physiology. And not only have I been doing it, but I do it probably more often for the person who's sitting in front of me than for my own self. Generally, after I've gone through family history and I've got a sense of looking at their labs, I have a pretty good idea of what I think's got sitting in front of me. Often what I've got sitting in front of me is a person who's got significant pancreatic insufficiency, and a person who may have walked in the room going, I know I need to do something, but I'm not going to take those shots, okay? And I'm not going to sit there and try and persuade them about taking shots or not. What I'd quite like to do is demonstrate to them that actually they've got pancreatic insufficiency and maybe their only choice is to take shots. Okay, so the test that I do is a fasting C-peptide test. Probably the most important thing to point out here is you cannot do it alone. It has to be done with a fasting blood glucose. I'm going to repeat that. It is a completely useless test if you don't do it at the same time as the fasting blood glucose. You can't do the fasting blood glucose on a different day. You have to do them simultaneously. It is going to give us a measure of not only their pancreatic function, but it's also going to give us a suggestion around how much insulin resistance they have. I'm not at all interested in the actual numbers that you're going to get back. I'm going to repeat that. Do not focus on the actual value of the tests. That is not important. The important bit is the relationship between the fasting blood glucose and the fasting C-peptide. That is going to give you the information about their pancreatic function and whether or not they've got insulin resistance. Do not do these tests when the person has a high HbA1c. High sugars are toxic to pancreatic beta cells, which means they're not producing much insulin, and so you'll get a spuriously low information around pancreatic insulin function, okay? The tendency is to do this at the time of diagnosis. Oh, gee, I'm going to figure out what type of diabetes they have. You need to wait until you've got their sugars under better control before you can do this test. I'm talking about even an HbA1c of 9% would be fine, okay? And I would have to say, and I suppose I should have added this as an extra point on here, I think that you possibly don't get as good information if the person is already on insulin, on exogenous insulin, all right? But I have used it, particularly if I'm trying to make a point to a person about their function, because I want them to make the decision that they need to go on insulin. All right? Is that me? Oh, I don't work here. So, let's start by looking, and this is exactly how I present it to the person who's sitting in front of me. Let's start by looking at this picture that you're now all incredibly familiar with. A person who does not have diabetes. If we were to check their blood sugar when they're fasting, what we would expect to find is that it's going to be somewhere around a 70. And that's a reflection of what their liver is doing. The reason it stays at a 70 is because there is a matching insulin that's going to allow the cells to take it up. So if we measure the insulin level, which we measure by measuring a C-peptide, which is part of the insulin molecule, what we'd expect to find is that the level is going to be somewhere between a 0.8 and a 3.1. The numbers, as I say to the patient sitting in front of me, mean absolutely nothing to you. The point I want you to get, however, is there's this huge variability. It might be 0.8 on one day, but it might be 3.1 on another day. So there's huge variability in this, and that's why it's important that you don't look at the actual numbers. All right? What if we did these tests when the person had eaten? Well, then what we would find is that their blood sugar had gone up to around 140. Of course, there's going to be more insulin around because a person will have secreted more insulin to match that eating. And what we'll find is that the pancreas the level of the C-peptide may go up to something about like a 5. I've pulled these numbers out of my hat, all right? Okay, just to present the ideas. The point here is that the pancreas has, in a person who does not have diabetes, the pancreas has the ability to totally rev up their production of their insulin, all right? Let's say we took this person now who does not have diabetes and artificially pushed their sugars up to, let's say, 200. What would their normal pancreas do? Their normal pancreas would shove out a whole lot more insulin. In fact, there seems to be this no ceiling on this. A pancreas can just up its production of insulin in a person who's healthy. So let's take a look at the patient's blood sugar. When we tested them when they were fasting, well, lo and behold, it was 200. Then let's look at what their insulin production was when they had a blood sugar of 200, and it was 5. What does this 5 tell me? It tells me that they've got a reasonable amount of insulin available to them. What it tells me, however, is that the body isn't responding to it particularly well. But let's just focus for a minute and let's just leave it with the idea that we've got a reasonable amount of insulin available. Let's say we've got a different patient and their fasting blood glucose was 360, and when we measured their fasting C-peptide, it was also 5. What does this tell me? It tells me they've got a reasonable amount of pancreatic function, but they've got more insulin resistance than this person. Does that make sense? It's a relationship. It's a relativity. Let's take a third patient, fasting blood glucose of 450. Same C-peptide, reasonable amount of pancreatic function, but even more insulin resistance. Do you get the idea that this is about your experience with the numbers and how they relate to each other? This person might do very well with weight loss, pioglitazone, anything that's going to get their insulin resistance down, and if you could get them to lose enough, their pancreas may well do very nicely for quite some time. All right? Take a look at some others. Let's say you've got a person whose fasting blood glucose was 90. What was their matching insulin? 0.6. This person has primary pancreatic dysfunction and does not have insulin resistance. All right? Let's say a person has a fasting blood glucose of 270 and their C-peptide is 0.7. This person has primary pancreatic dysfunction, but they've also got some insulin resistance. What about this person, fasting blood glucose of 520, pancreatic function of 0.7. They've got even more insulin resistance, but they've got primary pancreatic dysfunction. And finally, this person, they've got insulin resistance, but they've got an awful lot of pancreatic function available to them. But it's hit its limit, and it can't get it down because of the insulin resistance. Does this make sense? It's pretty straightforward. It's pretty simple. It's a little bit like looking at thyroid TSHs and free T4s. It's a relationship. It's not a number. All right? Any questions? Please be sure to go back and ask family history, personal history. They will give you your biggest clues. Use your tests, your blood tests, cautiously. They're expensive. With the blood tests that I've given you at the end, they're a beautiful way of communicating to a patient what's going on with their own physiology. Thanks a lot.